بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Good evening, everybody, wherever you are, and happy to have you in the third day of our conference about the trends of pharmacy education. We are coming close from the end of this activity, and we hope that you have ended up with new insights, opportunities for the pharmacy education. And hopefully you have enjoyed also the activities so far. Today we are going to listen and discuss some of our postgraduate students, the master and PhD students. We are going to listen to their projects and discuss them with the results they have got. And at the end of the day, we are going to select the best from these presentations, depending on your own polling, electronic polling at the end of the session. So good luck to everybody. The stage is with Dr. Masar now.
Thank you, Dr. Anam. I'm Dr. Masar Mohammed. I will be with you for the remaining time of the third day of our conference, online conference, sharing this with Dr. Atmar Habib. I recommend and advise our attendees to take a pen, a pencil, and a piece of paper to take notes and question, because we have very, very valuable presentation. Just a reminder, we have 10 minutes for each presentation and 5 minutes for question and answer. The first presentation with us, according to the net issues, we will have today Nuha. So Nuha, her presentation and the title of Preparation and Evaluation of Porosity Osmotic Pump Tablets for Sustained Release of Glimepiride. Let me introduce Nuha Mohammed Abdel Khalib for you. Nuha, she's her basic science in pharmacy in 2017 from Rashid University, and she's recently done her Viva at 14th of June 2020. So we have very, very fresh student with us. Now the mic with you, and you can share the slide with us.
Assalamu alaikum. Firstly, I would like to present myself. I am Nuha Mohammed, MSc at Pharmaceutical Department. بسم الله الرحمن الرحيم. ويسألونك عن الروح. قل الروح من أمر ربي وما أوتيتم من العلم إلا قليلا. صدق الله العلي العظيم. Today I will talk about a preparation and evaluation of porosity osmotic pump tablets for sustained drug release, which contain introduction followed by aim of study, then experimental work with result and discussion, finally conclusion. The porosity osmotic pump tablets. This formula have the ability to release the drug via a 24-hour through release the drug via the pores that's found on the surface by using pore-forming agents. Example on pore-forming agents like sorbitol and urea. The drug release rate from porosity osmotic pump tablets depending on various factors like drug solubility in the core of tablet, the osmotic pressure variance across the membrane, the leakageable level of pore-forming agents, and thickness of coating. The drug used within this study was the Glimepiride. The Glimepiride is drug that belongs to sulfonylurea, which is used for treatment patients with diabetic types 2. The dose of Glimepiride and the dose interval depending on patient's condition. So, for uncontrolled patients with diabetes can be taken the Glimepiride within divided dose. However, the total dose should not exceed 8 mg daily. This slide shows the chemical structure of Glimepiride. The aim is to provide sustained release of Glimepiride as a single dose over 24 hours to increase patients' compliance. The of preparation of coated tablet through weighting the proper weight, then sieving followed by shaking, and finally compress the powder by tablet machine to get the core. Then this core transfer into pan spray dryer machine to get coated tablet. This slide shows the different 15 formulation of the core of porosity osmotic pump tablets. The preparation of the coat through soaking and stirring the ethyl cellulose in ethanol for 12 hours. Then adding castor oil with stirring for 2 hours. And finally adding gingerol solution with stirring for 2 hours. The application of the coat on the porosity osmotic pump tablet through pan spray dryer. Via the tablet cores were placed in the pan for 15 minutes to warming the tablet cores before applying the spraying coat. Then the flow of hot air was used to aid in fixing the coating material droplet on the tablet cores. And finally, all coated transfer into oven within 50 centigrade for 4 hours to ensure the removal of all ethanol by evaporation. There are various factors affecting on the release profile of glimepiride from porosity osmotic pump tablets, which include the effect of super disintegrant concentration, the effect of molecular weight and type of polymer, the effect of different type of diluent, the effect of polymer combination, the effect of osmotic agents, and finally the effect of ethyl cellulose as coating agents. Now I am going to result and discussion. This slide shows the effect of super disintegrant concentration on the release of glimepiride. All these formula have the ability to release the drug through the first half hours. While this slide shows the effect of diluent type by the comparison between HCl as within F5, hydrojet L100 as within HCl as within F4, hydrojet L100 as within F5, and lactose monohydrate as within F11. The most retardation occur within hydrojet L100. While this slide shows the effect of molecular weight and type of polymer by the comparison between HPMCK4M as within F6, HPMCK 100M as within F7, carboxymethyl cellulose sodium as within F10, and finally carbobol as within F12. The most retardation occur within F7 because this formula have the ability to release the drug via 24 hours. This slide shows the effect between combination two polymer within formula. As within F8, the combination between HPMCK4M and HPMCK100M, while F9, the combination between carbobol and HPMCK4M. This slide shows the effect of ethyl cellulose as coating agent by comparison between the uncoated tablet and coating tablet. The uncoated tablet release the drug via 4 hours, while coated tablet release the drug via 24 hours. And finally, the effect of osmotic agents, so decreasing the amount of osmotic agents that lead to more retardation occur within the release of glimepiride. Now I am going to conclusion. The porosity osmotic pump tablets could offer as a once daily dosage form within 24 hours after release for 8 milligrams of glimepiride. Formulation 7 containing HPMCK 100 was the best one because it has the ability to release the drug via 24 hours. The osmotic agent principle is constituted to the formulation of porosity osmotic pump tablets, and when increased its concentration, that lead to accelerate the release profile of the drug. The addition of super disintegrant that lead to accelerate the release profile of a drug, and finally the combination between two polymer with the presence of osmotic agent or osmotic salts that lead to decrease the total viscosity of formula. Thank you for your listening and attention. Any question?
Thank you, Nuha. Thank you for your nice presentation. Nuha, can I ask a question? I know there's an osmotic tablet, but why this called porosity osmotic home tablet? Do you hear my question? Do you hear it? Okay. Why this kind of tablet is called porosity osmotic home tablet?
Okay, because when putting the osmotic agent inside the core or inside the tablet, after it dissolves within the solute, that lead to increase the pressure inside it, so that leading to pushing the drug out from the formula via pores that's found on the semi-permeable membrane.
Mm-hmm. What kind of pumping agent? So then with someone who doesn't have an idea about this kind of tablet. So what is the things that make the drug pumping out?
Okay, it's ionic compound, example on hydrophilic polymer or strong electrolyte salt. Strong electrolyte salt like NaCl, KCl, and hydrophilic polymer like ethylene oxide.
So
also some research using the glucose as osmotic agents, but my project for patients with diabetic, so I didn't choose the glucose, sucrose, or other from this kind.
Okay, so if I ask about the goal of your work, is it for like, do you want to delay the release of your drug? You chose glimepiride. So is that what you want from your work? To delay the release, to control the release? What do you want?
For sustained release, for release the drug via long time or over long time.
So
the control release,
you delayed the release of your drug for a long period of time. Have you controlled the release of the drug?
The control release always applied on the zero order or for targeted the drug for a specific site. My aim was not
to control the release. Okay. So I've seen something in your presentation that you warm the core of the tablet. Have you warmed the core of your tablet?
The core?
Yeah. You haven't warmed anything? Oh, I missed something maybe in your presentation.
The core is only compress the tablet, the powder of tablet, without coating.
Without coating. So why did you do that?
It's considered as one of the principles of osmotic tablet. It consists of core and coat, because its coat is a special coat, semi-permeable membrane.
Okay. Thank you, Nuha. Thank you for your being with us. Thank you for the presentation, for your answering the question. Thank you very much. Thank you. Now the time to go with the second presentation in our conference. It is under the title of the effect of vitamin D3 and CoQ10 supplementation on hormonal profile, ovulation status, and pregnancy outcome in women with clomiphene citrate resistant PCOS by Ansam Abdelamir Yahya. Let me introduce Ansam for you. Ansam her basic science in pharmacy in 2013 from Pharmacy College, Babylon University. She has an MSc in clinical pharmacy in 2019 from our college. And she's now working in the Imam Sadaq Teaching Hospital. She holds the responsibility of a drug information center. We are very happy to see you again, and Sam. Now the microphone with you. Can you share your slide with us, please?
Dr. Masara and Sam is having some technical difficulties, so I'm afraid that we'll have to skip back to Rafid Muhammad, the next candidate.
Okay. I get a message that we have a net issue. I think I will go with another presentation under the title of Synthesis, Anti-Cancer Evaluation, and Molecular Docking Study of a new pyridopyrimidine derivative as THFR inhibitors by Rafid Muhammad H. Hashim. Let me introduce Rafid. As I remember from his CV, he's finished his basic science in pharmacy in 2006, and his MSc in pharmaceutical chemistry in 2014, and he's now a student at research level. You are very welcome, Rafid, to present your work with us, and you can share your slide with us. Thank you.
Thank you, Dr. Masar. Good afternoon, ladies and gentlemen. I am Rafid Muhammad. I'm glad to be here today with you. Now let's get started with my presentation, which is entitled Synthesis, Anti-Cancer Evaluation and Molecular Docking Study of New Pyridopyrimidine Derivatives as DHFR Inhibitors. As a background, dihydrofolate reductase, DHFR, catalyzes the reduction of folic acid to tetrahydrofolates in two-step reaction with the use of NADPH as a cofactor. Tetrahydrofolate is an essential cofactor in the synthesis of purine thymidate, and so in the synthesis of DNA and RNA. This scheme for the conversion of folic acid to dihydro and tetrahydrofolate, the folic acid in the first step by the enzyme DHFR and cofactor NADPH, it will convert to dihydrofolate. Then by the same enzyme and the same cofactor, it will be converted to tetrahydrofolate. Tetrahydrofolate is the active form of the folic acid. Inhibition of DHFR results in a depletion of the reduced folate pool, inhibition of RNA and DNA synthesis, then cell death. For this reason, DHFR has been recognized as important therapeutic drug target. DHFR inhibitors, which targeting the binding sites on the enzyme, have been used in the treatment of cancer, autoimmune disease, and bacterial and fungal infection. This is the methotrexate mechanism of action, in which methotrexate inhibits the enzyme DHFR in the two-step for conversion of folic acid Methotrexate and folic acid is the presence of amino group instead of hydroxyl group in the folic acid, and the addition of methyl group in this position for methotrexate. While the tail of the compound is the same, the para-aminobenzoic acid and the glutamic acid is the same in the folic acid and methotrexate. This position of carboxyl, in this position, the polyglutamate add another glutamic acid molecule and make the polyglutamation. Polyglutamation is responsible for the retention of the drug inside the cancerous cell. Increased polyglutamation is observed in the malignant versus normal cell, which can partly explain the selectivity for methotrexate for malignant tissue. Polyglutamation occurs in the cancerous cell in a greater rate than the normal cell. Methotrexate polyglutamate also inhibit other folate-related enzymes, including LTS, thymidylase synthase, glycinamide ribonucleotide formyltransferase, and aminoimidazole carboxamide ribonucleotide formyltransferase, which all of these enzymes participate in the purine biosynthesis, and so it is important in the DNA and RNA synthesis. The other type of antifolate is the non-classical one. Non-classical antifolate, these inhibitors end with lipophilic substituent instead of glutamic acid. So they did not have glutamic acid residue or glutamic acid tail. Suppression of the glutamic chain of the skeleton leads to the compounds that are not substrate for the folate active transport system and enter the cell by passive diffusion. We should note that the methotrexate can enter the cancerous cell by active transport, while this type of antifolate, non-classical, enter the cell by passive diffusion because it is lipophilic. Also, they have the advantage of being active in cancer cells that are resistant to methotrexate because of the transport defects. The lacking of glutamic acid side chain prevents polyglutamation, and therefore these compounds are not retained within the cells and require more prolonged treatment. As an example for the classical one of antifolate, trimethyltrexate and enoltrexate, we note that there is no glutamic acid tail in these compounds. Some notes about methotrexate treatment. The two problems that represents the major obstacles to the effective treatment of neoplastic disease with methotrexate as well as with other anti-neoplastic agents are toxicity and resistance. Methotrexate is known for its severe serious side effects, for example, bone marrow suppression, gastrointestinal lesion, renal insufficiency, hepatic failure, and hypoalbuminemia and pancytopenia. Also, methotrexate resistance may occur rapidly and can lead to treatment failure. So the most dangerous one is the resistance and the toxicity for methotrexate. What is the resistance mechanism for methotrexate? Resistance mechanism for methotrexate, there is 5 different resistance mechanisms for methotrexate, which is number 1, decreased accumulation due to impaired transport. 2, decreased retention as a consequence of lack of polyglutamate formation. 3, an increase in DHFR expression. 4, altered mutated DHFR that binds methotrexate less avidly than normal enzyme. And finally, an increase in the level of lysosomal enzyme, which is gamma glutamate hydrolase that hydrolyzes methotrexate polyglutamate. Pyrimidine derivatives. We use this ring system or fused ring system, fused pyrimidine derivative, as a nucleus for our study. Pyrimidine derivatives display usefulness in the fields of chemotherapy. It was reported that the chemotherapeutic efficacy of pyrimidine derivatives is related to their ability to inhibit vital enzyme responsible for DNA biosynthesis as dihydrofolate reductase. Further, pyrimidine and fused pyrimidine derivatives show biologically important activity because of their structural similarity to purine pyridine system. A new methotrexate analog. The search for a new methotrexate analogs take generally 2 approaches. The first approach, replacement of pyridine by other ring system. Pyridine is the ring system in the folic acid, which is that. The first approach is the replacement of pyridine by other fused ring system. The second one is altered GABA and glutamic acid parts by more lipophilic moiety. This part of the molecule will be replaced by other more lipophilic moiety. The first approach, which is replacements in the ring system, is preferred. so as to keep polyglutamation and the transport via reduced folate carrier active. Polyglutamation is very important for cytotoxic activity due to, number one, increased intracellular retention. Number two, markedly increased affinity for certain folate-related enzymes, which include thymidase synthase, TS, glycinamide ribonucleotide formyltransferase, GART, and ACRT. We go to the aim of our study. The aim of our study is, number one, design new DHFR inhibitors. Those have potent anti-tumor activity utilizing modern software supplied by the Cambridge Crystallographic Data Center, CCDC, the GOLD software. And number two, synthesize the best fitted structure achieved with the software and purify the final product. Three, characterization of the purified final compound with the related analytical instrument like FTIR, NMR, CHN analyzer. And finally, examine these potential DHFR inhibitors on a specific cancerous cell line culture biological evaluation. This is a simplified scheme for the synthesis. We use a fused pyrimidine ring and reacted it with a para-aminobenzoic acid, substituted para-aminobenzoic acids to give this molecule. Then this molecule is reacted with glutamic acid to form the tail of the compound, and it will be bound by amide bond. Characterization of the structure, a number of sensitive and reliable spectroscopic technique will be used, such as FTIR and NMR and CNMR also. Let's talk about docking study. The docking analysis for the proposed compound performed using GOLD software, genetic optimization for ligand docking, Cambridge Crystallographic Data Center. GOLD is one of the finest molecular docking software used to dock the selected ligands into the active site of the enzyme. So first, we choose our compound depending on the docking study. Then, depending on the results, we synthesize this compound. This is the docking study, and this table simply it's contained the PLP fitness. The PLP fitness is the scale of the binding between the protein and the compound. PLP fitness, the score. This is the number of hydrogen bonding between the ligand and the protein, and the amino acid that is involved in this H bonding. As the number of PLP fitness, it is compared with the methotrexate. Methotrexate have the value of 74. Many of our compounds have much higher value from this, and some of them are unequal methotrexate. So according to these results, we synthesize this compound and perform biological evaluation. The examination of these potential DHFR inhibitor on the different cancerous cell lines using tissue culture techniques to investigate compounds. Note that the methotrexate, the reference drug, have a 20 IC50. IC50 is measured by micromolar. Methotrexate is about 20, and the compound 13, compound 15, and compound 13E have good results as compared with methotrexate. Thank you very much.
Thank you, Rafid, for your presentation. It's really very interesting, at least for me. And I think many people here with us are interesting too. I just want to say sorry for Zaid Al-Ubaidi. I couldn't catch your question from Q&A. If you have any question for Rafid, I will be very happy to take it from you. But let me ask you, Rafid, do you conjugate the folic acid with a drug with methotrexate? Am I right?
Conjugation between methotrexate and folic acid?
Yes.
Or conjugate the drug with folic acid?
The drug with folic acid, yeah.
No. There is no conjugation. we start from the beginning.
Okay.
We start from the beginning and make a compound have a similar properties to methotrexate, the same structure, but
Okay.
we manipulate in the ring system, in the heterocyclic ring system.
Okay. Okay.
So it is
so
methotrexate analog. Methotrexate analog.
Method analog, yeah. You did docking study, so I know it is computer work. So did this help you? Did you get like a result which support your data with cell line work?
Yes, that's a great question. The GOLD software is very helpful for the medicinal chemist, pharmaceutical chemistry, because it's save time and decrease the cost for synthesis. We study the docking software too much in the study for docking software, and it helped us very much in our study. Yes.
Okay, so it helps you.
Yes, too much.
Okay, so there's a question from a friend. He said, ask Rafid, which class of antifoliated drug is better, the classical or not classical one?
The classical or non-classical one? Both the classical and non-classical one have advantage and disadvantage. But the classical one, like methotrexate, the main drawback for it is the resistance. And when there is a resistance in the patient, they tend to increase the dose, and this leads to side effects. In non-classical one, they try to solve this problem. They try to use more lipophilic compound that can enter the cancerous cell by passive diffusion. They thought they can decrease the resistance and decrease, but this is occur with a little success for the non-classical. According to my result, the classical one is better.
Okay. There's a question from Zaid Al-Ubaidi. He said, have you what about toxicity profile?
Yes.
Have you included something about toxicity profile in your work?
pH profile?
Toxicity.
Toxicity.
Yes.
Yes. We did not get the toxicity, but we do only the cell line.
Yeah.
Inshallah, and cumulative.
So you are still working. Good for you, Rafid, and we are very happy to have you with us, sharing these nice results, and good for you and for Dr. Mandar also. Thank you very much. Now the time for third presentation. I will turn back to Ansam. Ansam, her title of a presentation is the effect of vitamin D3 and Q10 supplementation on hormonal profile, ovulation, status, and pregnancy outcome in women with clomiphene citrate resistance PCOS. Ansam, she's her basic science in 2013 pharmacy from the pharmacy school, Babylon University. Her MSc in clinical pharmacy in 2019 from our college, and she's now working in Al-Imam Sadiq Teaching Hospital and holds the responsibility of the Drug Information Center. It's good to see you again, Ansam, and you are very welcome to present your work. You can share your slide with us, please. Thank you.
Thank you very much. Thank you very much to everyone in this important international conference. Good evening, and I am very happy to participate in this conference, and I would like to thank everyone in this conference. I will start to share my screen. And I am very sorry for any interruption occurred because of the network problem. Okay. The title of my presentation is about the effect of vitamin D and coenzyme Q10 on hormonal blockade, ovulation status, and pregnancy outcome in women with clomiphene citrate resistance polycystic ovary syndrome. My topic and presentation include introduction, aim of study, patient and method, results, conclusion, and finally recommendation. And because of time limitation, I will talk very speed about the introduction. Polycystic ovary is one of the most common endocrine heterogeneous disorders in women at reproductive age, first described by Steen and Leventhal in 1935. The worldwide prevalence is about 4 to 12%. While regarding PCOS infertility, which is considered one of the primary infertility, and in Iraq, studies show that prevalence of PCOS infertility is about 33% in IVF center study in Erbil Hospital. The oxidative stress and inflammation in PCOS, as we know, insulin resistance is very common in PCOS and lead to hyperglycemia, and hyperglycemia affect the mononuclear cell to produce more reactive oxygen species, which affect on the body cell that increase the nuclear factor kappa and TNF-alpha, which have feedback on insulin resistance and hyperglycemia again. Regarding the sign and symptom of polycystic ovary, has many signs and symptoms due to hyperandrogenemia, such as acne, hair thinning and loose, excessive body and facial hair, in addition to irregular menstruation, a sign due to insulin resistance, such as weight gain, high blood pressure, also stress and depression, in addition to multiple ovarian cysts that we see in ultrasonography. The diagnosis depends on Rotterdam criteria that the patient confirmed with the PCOS if she has 2 out of 3 criteria that include androgen excess, either clinical or biochemical, ovulatory dysfunction, either oligo or anovulation. And finally, the third criteria is the polycystic ovary on ultrasonography, that at least one ovary with 12 follicles measure 2 to 9 millimeter, and the volume of ovary is more than 10 ml. In addition to the exclusion of other etiology, management includes 3 points: lifestyle modification, which is very important, including exercise, low fat and sugar diet, weight reduction, medical treatment, and surgical treatment. The supplement that I use and I am used in my study is vitamin D. As we know, vitamin D deficiency is very common, and especially in PCOS, approximately 67 to 85% of women with PCOS have vitamin D deficiency, and many clinical trials studies the effect of vitamin D supplementation or its analog on insulin secretion, lipid profile, menstrual cycle, and follicular development. Various mechanisms explaining the role of vitamin D in human reproduction. The first one is through the direct stimulatory effect on aromatase gene expression in the reproductive tissue, which is important for ovulation. The second mechanism through the Hox-10 gene expression, and the Hox-10 gene is important for the development of the uterus and for endometrial development, allowing uterine for receiving after implantation of the fertilized ova. The third mechanism is that vitamin D is the key regulating hormone for calcium homeostasis, and the calcium play important role in oocyte activation, maturation, so result in a follicular development. The second supplement used in my study is the coenzyme Q10, which is the only lipid-soluble antioxidant synthesized in a human body and reduce oxidative stress itself, and in its reduced form, ubiquinol. So inhibit lipid peroxidation in biological membrane and also in LDL. Also have anti-apoptotic effect, and as we know, the apoptosis is important mechanism and the main mechanism involved in follicular cohort atresia. Another mechanism is that of CoQ10 in improving insulin metabolism marker and also modifying the insulin and the adiponectin receptor and inducing the tyrosine kinase and the phosphatidylcholine kinase activity in the liver. These enzymes are also involved in the improving the insulin cascade and increasing the glucose transporter and tyrosine phosphorylation. Other proposed mechanisms include the regulation of the insulin receptor, glucose transporter, lipid profile, and redox system. The aim of my study is to assess the potential effect of vitamin D and coenzyme Q10 supplementation on serum hormone level, including free testosterone, follicular stimulating hormone, luteinizing hormone, LH to FSH ratio, and the anti-Mullerian hormone. The second point is to assess the potential effect of vitamin D and coenzyme Q10 on serum antioxidant اللي هو الجلوtathione. The final aim is to assess the potential effect of vitamin D and CoQ10 on improving the fertility outcome. The fertility outcome including the mid-cycle transvaginal ultrasound, the ovulation stimulation, using the mid-cycle transvaginal ultrasound, and the pregnancy rate using the pregnancy test and ultrasound. Patient and method. The study design is a prospective, comparative, open-label interventional study conducted in a private clinic, gynecologic and obstetric private clinic, from September 2017 to April 2019. A total of 45 patients was enrolled in the study, but only 41 patients completed the study. The candidate patient who visit the clinic suffering from oligomenorrhea for more than 1 month, menstrual regulation was achieved by using progesterone, allele estranol, 5 mg tablet twice daily for 10 days, and then entered the study. Patient criteria, inclusive criteria, PCOS patient diagnosis according to Rotterdam criteria, who are age range from 19 to 40 years, and desire to be pregnant. It is important to desire to be pregnant, not only for treating other problems associated with polycystic. Patients with PCOS who are clomiphene resistant, clomiphene citrate resistant, and this also important point means that take clomiphene citrate for at least 2 to 3 months and without ovulation, or ovulate very thin endometrium, less than 5 millimeters. Final point is that the patient with PCOS that have vitamin D deficiency less than 20 nanogram per ml, was enrolled in one group, and patients who have insufficient vitamin D level from 20 to 30 nanogram per ml, or sufficient vitamin D more than 30 nanogram per ml was enrolled in another group. Well, the exclusive criteria, PCOS patients that have on oral contraceptive or use other ovulation stimulators such as letrozole. Also, who take another medication such as the statin, beta blocker, tricyclic antidepressant. Also, patients who have other gynecologic or hormonal diseases such as hyperprolactinemia, thyroid dysfunction, hypercortisolism. Final exclusive is that using other supplements such as the myoinositol, melatonin, and the omega-3. This is the study group, group 1, including the 24 PCOS patients assigned to be treated with clomiphene citrate. Both groups take clomiphene citrate 50 milligrams twice daily after meal for 5 days. Group 1 plus vitamin D 10,000 international units for 2 months after meal, and group 2 plus coenzyme Q10 soft gel capsule 2000 milligrams after meal for 2-month period. This is the patient flow chart. Study intervention: blood sample was withdrawn from patient before intervention during the day 2 to 5 of cycle for hormonal evaluation and vitamin D to group the patient accordingly. All patients was followed up via transvaginal ultrasound at day 10 and 12 of cycle to determine the number of growing follicle size less than 14 millimeter and dominant mature follicle whose size from 18 to 22 millimeter, and accordingly, when at least one follicle matured, measuring more than or equal to 18 millimeter, then HCG pregnil injection 5,000 to 10,000 international units was administered, and advised the patient to have intercourse throughout 24 to 36 hours after HCG injection. Serum HCG or pregnancy test was determined 2 weeks after HCG injection in the absence of menstruation, and when diagnosis of pregnancy occurred, blood sample was collected from the patient for post-treatment measurement. while patients who complete the first month without pregnancy entered the second month with the same intervention, and at the end of the second month, blood sample was collected from the patient regarding pregnancy. The laboratory and gynecologic measures in the study include hormonal parameter, free testosterone, follicular stimulating hormone, luteinizing hormone, FSH ratio, and anti-Mullerian hormone, endogenous vitamin D status, oxidative stress biomarker, glutathione. Some shortage occurred in post-treatment data due to the availability and the specificity of some tests at the sampling time. The gynecologic measure included ultrasound, transvaginal ultrasound, to determine the overall pregnancy rate through the ovulation stimulation and the number of ova, and also the endometrial thickness, and finally the pregnancy test. The result regarding the demographic data, we see in this baseline distribution of demographic data about 58% of the patient in vitamin D group, age from 19 to 34. The residents mostly rural. The body mass index average is 26, and mostly about 16% are obese or percent of the study patient, and age range from 18 to 31, and also the residence is mostly rural, and also the body mass index are mostly obese and overweight, and 59% have duration of symptom 2 to 10 years. There is no significant difference between the study group regarding the socio-demographic characteristics. Regarding the effect of vitamin D and CoQ10 on free testosterone, pre-treatment, the free testosterone level was elevated compared to the normal level of free testosterone in women. And after treatment, we see that there is significant decrease in testosterone level after vitamin D supplementation, while no significant decrease after CoQ10 supplementation. Regarding FSH level, there is no significant increase after both intervention in both study groups. While in LH, the decrease was significant after both vitamin D supplementation and CoQ10 supplementation, and this very important result. Regarding the effect on LH-FSH ratio, also the decrease was significant in both study groups because of the significant decrease in LH ratio. Regarding the effect on anti-Mullerian hormone level, pre-treatment was higher than normal level for women at the reproductive age, while after treatment there is decrease in the serum anti-Mullerian hormone, and the decrease was significant in both study groups. Regarding the effect of vitamin D and CoQ10 on endogenous vitamin D status, as we know, the group that give vitamin D, their vitamin D level was elevated in 100%, and the increase was highly significant. While in group 2, who do not give vitamin D, there is decrease in vitamin D level, also significant. Regarding the effect on antioxidants through the serum glutathione, also there is significant increase in serum glutathione level in 19% after vitamin D supplementation, and in 85% after CoQ10 supplementation. While the effect on ovulation stimulation, pre-treatment, the ovulation was positive, mean the ova size more than or equal to 18 millimeter. Only 2 patients have positive ovulation in group 1, while post-treatment with vitamin D, 18 patients have positive ovulation. And in group 2, only 1 patient pre-treatment have positive ovulation, and after treatment there is 13 patients have positive ovulation. This figure shows the overall effect. Before intervention, the blue color shows that is only 10% have positive ovulation pre-treatment, while after treatment, the blue color shows that about 75% have positive ovulation. Regarding the effect on pregnancy outcome, there are only 3 patients become pregnant in group 2 or 3 patients, and no significant difference in a pregnancy outcome between groups. This is the overall effect on pregnancy outcome, that about 15% of all patients become pregnant. Conclusion. Vitamin D deficient patients show elevated free testosterone baseline level and was improved after vitamin D supplementation. No effect for both intervention on follicular stimulating hormone level. Meanwhile, the LH level was decreased significantly, and similarly the LH-FSH ratio in both study groups. The baseline AMN anti-Mullerian hormone was increased in both study groups, and after intervention, the level was decreased to normal. There was improvement with antioxidant status after intervention in respect to endogenous glutathione. The overall therapeutic outcome of both intervention regarding the improvement in ovulation stimulation in 75% and in overall pregnancy outcome was 15%, equally distribution in both study groups. The final recommendation intended studies is warranted to explore the effect of vitamin D and CoQ10 in PCOS patients on other metabolic and hormonal profiles such as body mass index, fasting blood glucose, fasting serum insulin, and accordingly HOMO-IR, lipid profile, sex hormone binding globulin, thyroid stimulating hormone, estradiol, prolactin, blood pressure profile. Further study about the effect of vitamin D and CoQ10 on oversize, endometrial thickness, response rate to stimulation, and the pregnancy versus the abortion rate. As we know, the abortion rate is higher in PCOS patients, which is one of the complications of PCOS. Studying the correlation between endogenous vitamin D status and oxidant status, ovulation, and the pregnancy rate with the metabolic and hormonal change. Subjective assessment such as the quality of life of anti and biomarkers such as interleukin and MDA, THC, oxidized LDL after vitamin D3 and CoQ10 supplementation. Finally, this is my reported research in ResearchGate. Thank you for listening. If there's any question.
Thank you very much, Ansam, for your presentation, for being with us from Al-Hilla. Thank you very much. Before going to ask Ansam a question, I just want to say to our attendees, please stay with us. We have voting at the end of this session by you to vote which one is the best presentation by, in your opinion. So return back to you, Ansam. Do you think that this polycystic ovarian differs between married women and non-married women in terms like of symptoms, treatment protocols?
Sorry, Dr. Repeat the question.
Okay, I will say it again. Does PCOS differs between married and unmarried women in terms of incidence, symptoms, treatment, and treatment protocols?
There is difference between married and unmarried according to what we need. If we need a pregnancy, the management different from if we need only management the other signs such as excess hair, menstrual irregularity. We give oral contraceptive, while those who need to become pregnant, we cannot give oral contraceptive. We give ovulation stimulator such as clomiphene, anastrozole, IVF.
Okay, so there's a question from Dr. Widat Al-Ani. She said, what's your aim is to study effect of vitamin D and or Q enzyme? I mean, which one was your aim in your work? Was both or one of them?
Because I cannot give only vitamin D and compare with control that who do not give only clomiphene citrate, which is resistance. The doctor refused to give the patient placebo, placebo only فخلينا يعني جانا الدراسة يعني تكون comparative أفضل، لأن الطبيب ما قبل إنه ننطيه يعني يقول هي جاية تريد pregnancy يعني، فممكن أنت تنطيها فقط كلوميفين تعطيها بلاسيبو يعني رفض هذا الشيء ethically ما قبل، فلهذا إحنا خليناها comparative وشفنا يعني أكو دراسات على الكيوتين بمصر يعني خصوصا بالكلوميفين ستريت resistance فدخلناه ويا الفيتامين.
Okay, so it was like a doctor decision in addition to the research literature. What could be the reason behind like poor response to clomid? Why?
One of the problem with the clomiphene is either anovulation resistance or hyperstimulation. Some PCOS patients have hyperstimulation and the ova become very large, more than 30 millimeter, and become cysts. And there is also no pregnancy. And the other problem is there is resistance, no ovulation, and occur in high percent of patients taking clomiphene, in about 25%.
Okay, there's just one question. So how long the treatment from your study, treatment duration is necessarily to treat or to overcome the infertility by using this vitamin D or CoQ?
From my study, يعني تقريبا هي ثلاثة patient هم become pregnant during the 2 months, but after 2 months يعني أنا استمرت متواصلة ويا البيشنت، هواي بقوا يعني صار عندهم pregnancy لأن تحسنت الهرمونات مالتهم، الهرمونات بروفايل improve after treatment، فيعني صاروا بالشهر اللي بعده أو اللي بعده صاروا يعني pregnant تقريبا هم فيهم 7 أو 8.
That's great. So you advise people or women, specifically who wants to get like pregnant, to take vitamin D3? Is that good?
Yes, and the doctor that I make research with her and him, Dr. Haidar Abbas Al-Attar and Dr. Bushra, give vitamin D to all patients. يعني they يجون للعيادة يسوي لهم vitamin D level and give vitamin D and show improvement, not only in PCOS, also in miscarriage.
That's good.
And abortion.
Thank you. Thank you, Ansam. Thank you for your answer to this question. Thank you for being with us. Thank you very much.
Thank you very much.
Thank you, Ansam. Now the time to go with the other presentation on the title of curcumin as adjuvant therapy to meloxicam in treatment of patients with knee osteoarthritis, evaluation of antioxidant activity by Mace Saadi Bakr. Let me introduce Mace Saadi for you. She got her basic science in 2011 from Ajman University for Science and Technology, UAE. And she finished her MSc in Clinical Pharmacy in 2019 from our college. It's good to see you again with us, Mace. The mic is with you now, and you can share your slide. Thank you very much.
Okay. Assalamu alaikum. Let me share just. Good evening, everyone. I would like to thank all the organizers of this webinar for giving me the opportunity to share my work with you. I'm really honored and very happy and excited to talk about my study that entitled Curcumin as Adjuvant Therapy to Meloxicam in Treatment of Patients with Knee OA, Evaluation of Antioxidant Activity. The content is introduction, patients and methods, results, conclusion, and recommendation. I'll be starting with a brief introduction. OA is the most widely prevalent chronic condition, particularly among elderly people. OA is a joint disorder caused by cartilage loss, resulting in joint pain and loss of functional capacity. OA is no longer perceived as a wear and tear phenomenon. Thus, it has been proposed that altered inflammatory state is the cause and mechanical stress is the inducer. Pathogenesis of OA is an interplay between mechanical factors, immune system, and metabolic factors, which lead to loss of cartilage and expansion of chondrocytes with the contribution of oxidative stress and pro-inflammatory cytokines, cartilage degradation enzymes, matrix component breakdown, which lead to cell apoptosis and then pain and physical disability. Oxidative stress is one of the major contributors to OA pathogenesis. Normal metabolic processes in osteoclasts, chondrocytes, and synoviocytes produce free radicals, ROS, and their derivatives. These toxic chemicals can backen bones and synovial joints, and together with the inflammatory mediators, they can result in extensive structural damage, inflammation, and eventually cell death. To diagnose OA, physicians need to take medical history, do clinical examination looking for signs and symptoms correlated with radiological findings, in which X-ray is the gold standard for diagnosing OA, and less commonly lab tests. Till the date, there is no cure for the disease, in which all the therapeutic options available is to manage signs and symptoms. There is non-pharmacological therapy that include lifestyle changes and physical therapy. Pharmacological therapy that include paracetamol, NSAIDs, corticosteroids, hyaluronic acid. Natural and alternative therapies. We can use techniques like acupuncture and hydrotherapy. And nature blessed us with so many incredible herbs and compounds that has so many health benefits for our bodies, like resveratrol, boswellia, chondroitin, glucosamine, omega-3, and on top of them, curcumin, which is extensively researched over the past half century. And the research shown that curcumin, the component of the golden spice turmeric, can modulate multiple cell signaling pathways. Several clinical trials have addressed the pharmacokinetics, safety, and efficacy of this nutraceutical against numerous diseases in humans. In OA, it can exert a chondroprotective effect through actions such as anti-inflammatory, antioxidative stress, anti-catabolic activity that are critical for mitigating OA disease pathogenesis and symptoms. Effect of curcumin on osteoarthritis. First, curcumin can reduce pain and inflammation through inhibition of cyclooxygenase 1, cyclooxygenase 2, and lipooxygenase synthesis from the arachidonic acid. Inhibition of cyclooxygenase 1 and COX-2 lead to inhibition of prostaglandins and thromboxanes. Inhibition of FLOX and lead to inhibition of leukotrienes. Inhibition lead to inhibition of pain and inflammation and support homeostasis. Also, curcumin can exert antioxidant effect on target tissue by more than one mechanism. It can act as a free radical scavenger. It can raise level of endogenous antioxidant enzyme like SOD and glutathione. It can induce an antioxidant defense mechanism by modulating nuclear factor kappa, nuclear factor erythroid-derived 2, and activator protein 1. The aim of this study is evaluating the effects of adding curcumin to the non-steroidal anti-inflammatory drug meloxicam on pain and physical functions in patients with knee OA. Assessment of antioxidant activity of curcumin as additive therapy to meloxicam in patients with knee OA. Patients and methods. 62 patients initially enrolled in this study, but unfortunately only 42 patients have made it to the end, age range 30 to 70 years, who have a confirmed painful knee OA, 6 males and 36 females. Those patients were selected from the outpatient clinic at Baghdad Teaching Hospital. Inclusion criteria and exclusion criteria. Patients included if they had a confirmed diagnosis of mild to moderate painful knee OA, according to physical examination and radiological features, aged 18 to 70 regardless the gender. Exclusion criteria, patient excluded if they have severe cases of OA, patient with diabetes, cardiovascular diseases, renal hepatic dysfunction, diagnosed ulcer diseases, pregnant breastfeeding women, patients receiving injections containing steroids within 2 months before study, or other steroids treatment within 4 weeks before the study, patients who are allergic to any of the non-tested drugs. Study design. A randomized prospective open-label control study was assigned to include patients with painful knee OA. The study was conducted from October 2017 till June 2018 at the outpatient clinic at Baghdad Teaching Hospital. This is the study group flow chart. 62 patients diagnosed with mild to moderate knee OA. 42 patients were subjectively and objectively assessed. 20 patients dropped off the study. Study groups: Group A, 21 patients treated with NSAID meloxicam 15 mg once daily. Group B, 21 patients treated with NSAID meloxicam 15 mg once daily. Intermediate curcumin 800 mg, 2 caps once daily. Study interventions: patients were recommended to take meloxicam once daily after food, while curcumin 2 caps once daily before breakfast. Patients were regularly followed up to check on their compliance, medication consumption, or to detect any drug-related event. Methods: subjective assessment done by Oxford Knee Score, which is a concise questionnaire, consists of 12 questions concerning pain and physical function. Objective assessment done by evaluation of antioxidant enzymes SOD3 and glutathione reductase. Results: regarding demographic data and disease characteristics that include gender, age, BMI, smoking, duration of symptoms, they were all comparable between both groups. Effect of treatment on Oxford Knee Score after 3 months showed a highly significant improvement for both groups, but Group B showed a higher level of improvement, 81.7%. Regarding SOD3 serum level after 3 months of treatment, Group B showed a highly significant increase in SOD3 serum level, while Group A showed a non-significant change. Glutathione reductase serum level after 3 months of treatment showed a highly significant decrease in its level within Group A, while Group B showed a non-significant change. So in conclusion, curcumin supplementation as adjuvant to meloxicam showed better effect on pain and physical functions of knee OA patients after 3 months of treatment than meloxicam alone. Markedly significant increase of SOD3 level detected with curcumin plus meloxicam treated group in comparison with the group treated with meloxicam alone. Furthermore, a non-significant change of glutathione reductase serum level was noticed in Group B, whereas meloxicam showed significant reduction in GR serum level. Recommendations. This is the last part. Reassess the potential effect of curcumin alone or as adjuvant therapy to meloxicam or other NSAID, but with larger dose, since it has a high safety threshold. To assess curcumin effect on disease progression, longer period of treatment and follow-up is recommended because duration of only 90 days may be not enough for some patients. Evaluate the antioxidant effect of curcumin on different parameters in different medical conditions. Finally, according to the results of the current study and some previous studies, adding curcumin supplements to conventional therapy for knee OA have a promising synergistic effects which are worthy to be prescribed by specialists in aspect to its beneficial effect on overall quality of life, even in this pandemic. Since there is no vaccines, there is no specific cure for coronavirus, studies showed that curcumin has a really good benefit and inhibitory effect on coronavirus, and it improved the quality of life of COVID patients. And that's it. Thank you very much. Feel free to ask.
Thank you, Mays, for your presentation. Nice presentation. It's good to see you again in Corona time. I have a question for you. If you include like severe cases in your work, in your study.
Why I didn't include severe cases?
I didn't include.
Exclude.
Yeah.
Because severe cases need more period to follow up. They don't show improvement in 3 months. And also, usually severe cases in older people, they have comorbidities. We can't take patients with comorbidities.
Okay. do you think like curcumin? Because there's a question from a friend. So why you take curcumin before breakfast?
Well, it's the recommendation on the pack of the curcumin.
Okay. There is a question from Randall Jaburi. What is the effective dose of curcumin on your study? Have you studied this?
Why? I didn't get you.
The dose effect. Have you studied the dose? I mean, have you increased the dose or decreased the dose and show this effect on your patients?
No, I didn't decrease or increase the dose.
So you were like use a constant dose.
Yeah.
So do you recommend to use curcumin as a prophylaxis from osteoarthritis?
Yeah, sure, why not? Because as I mentioned earlier, curcumin, what I can say that one of the major contributors to OA is oxidative stress and inflammation. So by using curcumin, we can minimize the risk factors, some of them.
Okay. So actually, I usually take curcumin usually. So I'll persist taking curcumin according to your resultant data. Thank you, Mace, for your presentation. It's good to see you again. Thank you for being with us. Thank you. I just want to remind our attendees, please stay with us. Please vote to orientation. According to your voting, we will say who's the best in this day. So please keep yourself with us. Now I will go to my friend, Dr. Athmar. She will be she will be with you for the rest conference presentation. And thank you very much. Athmar, back to you.
Thank you very much, Dr. Massar. Our next presenter is Sarah Sidqi Ismail. She's going to present part of her work in the master titled Design, Synthesis, and Antibacterial Study of a New Agent Having 4-thiazolidinone pharmacophore. Sarah had her bachelor degree in 2009 from the College of Pharmacy, University of Mosul, and she works at the same university in the Department of Pharmaceutical Chemistry, and she's now at the end of finishing her master at the same subject, pharmaceutical chemistry. Welcome, Sarah, and it's good to see you again. The screen is yours, and you can start sharing your slides.
Thank you so much, Dr. Athmar. Thanks all the attendance. Good evening, and it's my honor to present my presentation in this conference. I will screen my presentation now. Okay, the name of my research is the Design, Synthesis, and Antibacterial Study of a New Agent Having 4-thiazolidinone pharmacophore, supervised by Dr. Mundhir Faisal Mahdi and Dr. Basma Munjid. The outline of my presentation, we will talk about the introduction, material, and method, and the results and the discussion. The introduction, the number of life-threatening disease caused by multi-drug resistance, gram-positive and negative bacteria has reached a frightening level in hospital and society. Infection caused by these species pose a serious challenge to the scientific community, and the need for effective therapy has led to a search for novel antibacterial agents. The mechanism of action of antimicrobial agent in general, it has many. First, the inhibition of bacterial cell wall biosynthesis, and this can be seen in drugs that restrict the creation of bacterial cell membrane like monobactam, penicillin, cephalosporin. Also, drug containing beta-lactam will prevent the formation of bacterial cell wall by impairing the enzyme which is required for the existence of the peptidoglycan network. Another mechanism is inhibition of a nucleic acid biosynthesis, like rifampicin will bind to the DNA-needed RNA polymerase that block the production of the RNA and leading to cell death. Or the use of fluoroquinolone like ciprofloxacin, levofloxacin will interfere with the DNA synthesis by stopping the DNA gyrase enzyme. Another mechanism is inhibition of protein biosynthesis, and this can be seen in drugs like chloramphenicol, aminoglycoside, macrolide, which will yield their antibacterial results by blocking the protein manufacturing. And we know that the ribosome of the bacteria is different in configuration from that present in the eukaryotic cell. So the antibacterial agent will take advantage of this variation and stop the bacterial growth. The aminoglycoside like tetracycline and macrolide will bind to the 13S subunit, while chloramphenicol will bind to the 15S subunit. Another mechanism is the inhibition of folic acid metabolism, as the production of the folic acid is blocked by drugs like sulfonamide and trimethoprim. So it will inhibit the DNA biosynthesis. And the usual antibacterial drug combination of trimethoprim and sulfamethoxazole will set off two-step throughout the bacterial folate synthesis pathway. And the last mechanism is cell membrane disruptor, and this can be seen in drugs like daptomycin, polymyxin, which will spread through the outer membrane and the cell wall of the sensitive cell to the cytoplasmic membrane. They trigger the breakage and destabilization and will lead to cytoplasmic leakage of the cell. On the other side, and this is a brief figure that explains the action of antimicrobial drugs on the cell of the bacteria. On the other side, the bacteria resist the antibacterial agents by different mechanisms, like inactivating the medication with beta-lactamase, acetylase, adenylase, or lowering the medication entering the portals of flu by using the unusual function of membrane trend, changing the drug goal in order that the antimicrobial has no longer bind to it, or it can be bypassing the drug's metabolism and growing tolerance to it. Our compound or our pharmacophore, which is thiolysdinone, the thiolysdinone 4 are derivative of thiolysdene ring, which has a carbonyl group at the 4th position, and it belongs to essential institution of heterocyclic compound that containing sulfur and nitrogen in 5-member ring. The existence of thiolysdinone rings in a broad spectrum of respected biologically active compound encouraged the scientists to synthesize several compounds comprising this ring in particular. Here are 4 thiolysdinone ring that we are talking about. The carbonyl group of thiolysdinone is highly unreactive, and the nucleus is called as the wonder nucleus, as it offers specific derivative with all exceptional kind of biological activity and pharmacological property, like antimicrobial, anti-inflammatory, antibacterial, and we can see that the antimicrobial activity is the most potent activity of 4-thiolysdinone, and it is strongly dependent on the nature of the substituent as C2 and N3 position. Here are some examples of 4-thiolysdinone derivative that has different activity as antibacterial, it may be anti-diabetic, or anti-inflammatory and analgesic. The aim of the work, the aim of my work, is to design, synthesize, and evaluate the antibacterial activity of a new analog of 4-thiolysdinone, comparing the in silico results, which is the docking study, with the in vivo results, and evaluating their ADME characteristic. Here are a brief scheme of my work. I started with 4-aminobenzyl alcohol, and then after esterification, we add hydrazine hydrate to form the hydrazone compound. The third step is Schiff base formation, and finally we add thioglycolic acid to close the ring and form 4-thiolysdinone ring. We done antibacterial assay of the compound with that we have made 5 from A to F. We use a trimethoprim as a reference, the DMSO as a control. The synthesized compound 5A to F are screened for their antibacterial activity against 4 types of bacteria: 2 gram-negative bacteria, which is E. coli and Acinetobacter species, and 2 gram-positive bacteria, which is Staphylococcus and Streptococcus. And the concentration we use is 62.5, 125, 250, and 500 microgram per mole, except also the control, which is used in the pure state. The results and the discussion. Here are the compound that we form with their molecular formula, the weight, description, the yield, and their melting point. We can see simple FTI results that prove that our compound has been formed. This is 5C compound. We can see the peak of carbonyl group at 1760, and also the bond between the carbon and the sulfur at 1236. The HNMR results that also prove that our compound has been formed is this, that prove the hydrogen of thiolysdinone ring that we can see from 3.40 to 3.58. Here are the antimicrobial activity on our bacteria, and we can see that compound 5C is the best compound action as antibacterial. It is even better than trimethoprim on some kinds of bacteria like Acinetobacters. And this can be seen in these graphs. This graph is the antibacterial activity of trimethoprim against E. coli. We can see compound 5C is almost nearby to the trimethoprim in its action. And here against Acinetobacter baumannii, we can see that compound 5C is better than trimethoprim at concentration of 500 at this bacteria. And on Staphylococcus aureus, we can see 5C has a good activity against this species. And finally, on Streptococcus pyogenes, 5C and 5B give almost equal results. This is still lower than trimethoprim, but it's also considered as a good result as antibacterial compound. The computational method and ADME study, the synthesized compound that we made, have evaluated for the prediction of their ADME property. By ADME, we mean absorption, distribution, metabolism, and excretion. The ADME property of our combined analog are considered by efficient and accurate tool by using Maestro software, and we successfully predicting their physical and pharmaceutical property. Here are the parameters we have used by using this compound, like the central nervous system activity, the brain-blood partition coefficient, etc. And these are the results of our compound. We see that all the compound, as a result, according to the value, all the synthesized inactive to the CNS, not crossing the blood-brain barrier, and they have good aqueous solubility, and there is no violation to the 5 rule of Lipinski. And regarding for predicting human oral absorption, we see compounds 5C and 5E have medium value, which is lower than 80, 100%, while compound 5A, B, D, and F has high oral absorption with percent value, which is higher than 800%. Our docking study, all the synthesized compounds are docked into the active site of the receptor. The binding, interaction, template, and orientation with the amino acid residues are investigated. All the compounds have a chiral center, and this generated 2 isomer, comparing with the trimethoprim as a positive control. And our results is matched to the biological experiment activity result. Here are a figure of the docking result of our compound, which is the base compound 5C. It has a docking score of -8.31. And this is the docking score of compound 5B, which has -7.72 as a docking result. And we should mention that trimethoprim has a docking score of -9.01. The dynamic results. What's the meaning of dynamic? Dynamic, we make a simulation of our complex, which is consist from the ligands and the receptor. The simulation are occur per time, per picoseconds. And the RMSD is the root mean standard deviation plot, show the interaction of all the selected complex insights into its conformational structure throughout the simulation time range. The analysis result of RMSD can determine the equilibrium of the fluctuation of all the amino acids till the end of simulation around the legended molecule structure. And for a brief examination of this figure, we can see that this red line will confirm the lesion of the drug, while the blue line is considered as the bacteria. As the 2 lines are fluctuating together, and the highest fluctuation is 2.4 angstrom, and this is the measuring unit for this plot, this means that our compound has considered and approved the condition for the synergy, and it is approved the condition, as many papers say that 2.4 angstrom is perfect for the complexation to be good with the receptor. Another figure about the molecular dynamics is this. These are the interaction between the amino acid residues and the receptor. We can see there is hydrogen bonding, hydrophobic, and water bridges. The highest amino acids that has these bridges is the aspartame 81. We can see that it has a hydrogen bonding and it has a water bridge. And this is, as it has a high, this means that this compound is stable, it will be fixed, and it will not changing, and it will be fit in the receptors of the protein. And the final figure here we will talk about the torsion bond. Each bond has a color, as you see in this figure. And these will study the torsion bond has a relationship with the flexibility of the bond, how it can be rotated. The first bond we can see is this between the hydroxine, OH, we can see this bond can be rotated to -90, -180, and also to 90 and 180. This means that this bond is so flexible, it can be rotated, so it has a lot of the potential energy with the torsion bond. On the otherwise, we can see this red bond between the NH and N. This bond, we can see the line here is straight, it is fixed, it is constant, it cannot be rotated. It cannot be rotated either to minus nor to positive. This means this bond has no much activity in the simulation, and it will remain fixed and cannot be flexible. Our conclusion of this study, first, that the synthesis of the design compound is accomplished. Second, the characterization and identification of the compound are verified by the assurance of the physical property, by the FTAR and the HNMR. The antibacterial assessment of the final product by the incorporation of electron donating group like OCH3 and NCH3/2 display remarkable activity than the electron withdrawing group. And all the active compounds are docked inside each active site of Staphylococcus aureus and E. coli and DNA gyrase beta crystal structure. By using Maestro software, comparing with the experimental results, this score approved the binding ability by the residues of amino acid. And finally, the results of ADME study suggest that the new compound will fulfill the Lipinski rule and will be absorbed from the GIT. Thanks a lot for your listening. I hope you benefit from this presentation.
Thank you very much, Sarah, for this presentation and for your work. So I have just a few 1-2 questions for you.
Yes.
Which software did you use with your docking study?
Excuse me, what?
Which software did you use?
It's a Schrödinger Maestro software package I use.
So there are other software for this kind of...
For docking, of course, there is another software. There is Gold.
So why did you choose that one?
This is the best. It gives the more accurate result, more reliable results, and this can be seen also from its high price that to register and have this program.
Okay. How? Another question is, how did you validate your docking settings?
Yes, I validate the docking by choosing the trimethoprim as a positive control and see the amino acid residues that the trimethoprim has connected in complex. And then we dock our synthesized compound in the same amino acid that complex with the trimethoprim. And we see almost nearby results. We can see trimethoprim has a docking score -9, and our compound 5C has a docking score -8.35. And another compound is -7.37, which is a good result.
It's good. We have a question from the question and answer as well. Nahad is asking, which parameter used for biostatistics? What are the main active amino acids at the active site of the enzyme?
There is many active amino acids. We can see aspartame, leucine, and this can be seen in the figure. There is no one in particular. There is another, it's combination. It's more than one amino acid.
So these amino acids are the parameters for biostatistics?
No.
She's asking which parameters did you use for biostatistics as well?
There is, I didn't make biostatistics in this presentation. There is no need for statics here.
Okay. Another question is, how did you calculate the concentration of methoprim as it contains 2 components, as she said? It's the same, Nahad? She's asking you the question.
No, I think only trimethoprim alone. It is not the combination that in the markets, there is trimethoprim and sulfamethoxazole, and also there is trimethoprim alone. I use the trimethoprim alone and make it the same concentration as our compound.
Thank you very much, Sarah. Thank you for joining us today.
Thanks, Doctor.
Welcome. We're going to move now to our next presenter, Ahmed Malik Kadhim. Ahmed is a pharmacist. He graduated from Al-Yarmouk College of Pharmacy in 2012. And currently, Ahmed is working with the Ministry of Health as a chairman of storage department in the Department of Pharmacy and Medical Supplies in Al Diwania province. Welcome, Ahmed. Ahmed's title today of his talk is Potential Effect of Berberine on Cytochrome P45017, Cytochrome B5 reductase serum glucose, and body weight in hyperandrogenized PCOS-induced female rats. Welcome, Ahmed, and nice to see you again.
Okay, thank
this
you,
is
Dr. Atmar.
yours, and you can start sharing your slides.
Thank you, Dr. Atmar. Now I will start to share my screen. Okay. I hope my screen now is full.
Yes, just enlarge it and we can hear you loud and clear. Just enlarge your slides.
Okay, thank you. Okay. My seminar today is about potential effect of berberine on cytochrome P45017, cytochrome B5 reductase, serum glucose, and body weight in hyperandrogenized polycystic ovarian syndrome rats. I think there is an issue. Okay. Okay. The outlines. Polycystic ovarian syndrome, we will talk about the pathogenesis and the hyperandrogenism. Then we will talk about our plant, which is berberine and its effect, the biomarkers that we will use in this study. After that, we will talk about materials and methods. Then we will talk about the results, discussion, and conclusion. Polycystic ovarian syndrome. As we all know, polycystic ovarian syndrome is a disease that occurs in many women. It is characterized by excessive hair growth, infertility, obesity, and mood change. The main triad of the polycystic ovarian syndrome is the insulin resistance, hyperlipidemia, and hyperandrogenism. As we can see here in the mechanism, there is a problem in the pulsatile release of the gonadotropin releasing hormone from the pituitary gland. Also, there is a defect in the release of the luteinizing hormone and follicle stimulating hormone from the anterior gland. Also, there is a progesterone and estrogen deficiency, feedback deficiency from the ovaries. Okay, the hyperandrogenism. There is an enhanced synthesis by the follicular theca cell in female with polycystic ovarian disease. This increase in gene expression can be seen due to the increase in the enzyme synthesis of the cytochrome C17A1. This cytochrome is responsible for the cleavage of the side chain of the side chain of the cholesterol to convert it to the estrogen and progesterone. Reducing hepatic synthesis also due to the reducing in the sex hormone binding globulin also lead to an increase in the testosterone free levels. Normal androgen synthesis and physiology. Approximately half of the testosterone originates directly from testosterone secretion by the ovaries and adrenal gland, whereas half is produced by the peripheral conversion of androstenedione. As you can see below, we have here two types of cells in the ovary. In the ovary, we have the theca cell, also the granulosa cell. Theca cell is responsible for the synthesis of LH hormone, and the granulosa cell is responsible for the synthesis of FSH hormone. We know that in the theca cell, androgen is synthesized in the female body. Then it will be transported to the granulosa cell. Then under the positive effect of the FSH, it will be converted to estrogen. In this scheme, we can see that under the positive effect of LH hormone, cholesterol is being converted to proglaninone. The proglaninone is then converted was interrupted. Excuse me, Dr. Athmar.
Yes, Ahmed. I think you had a problem with the internet.
Yes, now it's okay. It's okay.
Now it's okay. Yes, you can continue from where you stopped.
Okay. Okay. Let me see. Okay.
We're still waiting for the slides. Not yet, but we are still waiting for it.
I think there's a problem with the internet.
Yes, your slides is in now.
Okay, the slides in
yes.
now? Okay.
Just enlarge them.
Okay. Okay. I think we stopped here.
You can go back one slide. Okay. The previous slide. Yes.
Okay. Okay. Is that the required slide?
Yes.
Okay. Okay. We was talking about hyperandrogenism. We know that enhanced androgen synthesis by the follicular theca cell is the main cause of polycystic ovarian syndrome, hyperandrogenemia. And also the increased gene expression of the cytochrome P17, also a main cause of hyperandrogenemia. There is a reduction in the synthesis of the sex hormone binding globulin in the polycystic ovarian syndrome. As you can see here, approximately half of the testosterone is originated directly from the testosterone secretion by the ovaries and adrenal gland, whereas half is produced by the peripheral conversion of circulating androstenedione. In this figure, we can see that in the ovary, the LH is synthesized by the action of theca cell. Then the LH will stimulate the androgen synthesis. The androgen then will be transferred to the granular cell, whereby the action of the aromatase, it will be converted to estrogen. In this figure, we see that in the theca cell, cholesterol side chain will be cleavage to produce proglaninone. Then proglaninone is converted to the progesterone. Here, which is the crucial step, we can see that 17 alpha hydrolase will convert the progesterone to 17 hydroxy progesterone, and then it will be converted to testosterone. Then testosterone will be transported to the granular cell, and by the action of the FSH hormone, it will be converted to estrogen. Here, we can see that insulin also have a positive effect and negative effect on the conversion of testosterone to estrogen, to progesterone, and vice versa. Enzymes that regulate androgen synthesis. Cholesterol side chain cleavage by cytochrome 11A. Also, cytochrome 17A1 is the rate-limiting enzyme for the formation of androgen in the gonads and adrenal cortex. Cytochrome B5 strongly promotes 1720 lyase activity, principally by acting as an allosterically factor promoting the interaction of cytochrome C17 with the cytochrome oxidoreductase. Also, cytochrome oxidoreductase have a main role in the synthesis of androgens. Also, we have the serine threonine phosphorylation of the P450C17 itself by a specific MAP kinase, that means P38, appears to selectively promote the 1720 lyase activity. Berberine. Berberine is a quaternary ammonium salt from the protoberberine group of benzylcholine alkaloids. Berberine is a bush that have many pharmaceutical effects. Where we can find the berberine? Berberine can be found in Berberis vulgaris, which is a bush with red fruits. Also, Xanthorrhiza plant, in addition to the Californian poppy. Physiochemical properties of berberine. Berberine, after its extraction and manufacture, it will have a bright yellow and color with a very bitter taste. Berberine is now manufactured by chemical synthesis. Chloride or sulfate salt of berberine is generally used for clinical purposes. It is an intense yellow color, odorless, and characterized alkaloid bitter taste. It is very slightly soluble in water, slightly soluble in ethanol, and sparingly soluble in methanol. However, the salt form, that means the chloride and the sulfate form, are relatively more soluble in water. Pharmacokinetic of the berberine. Berberine could be absorbed in both rats and human gastrointestinal tract after oral administration. However, its absolute bioavailability is extremely low. Tissue distribution studies indicated that berberine could be widely distributed in rat organs, including liver, kidney, muscles, lung, brain, heart, and pancreas. And the concentration of berberine in most of the studied tissues was higher or much higher than that in plasma after 4 hours. Metabolism. The metabolism of berberine. After the administration of berberine, it will be absorbed. We know that it is poorly orally absorbed. Then it will be distributed extensively in the tissues, concentration more than the plasma. Metabolism in the intestine and liver, excretion by feces and bile. Berberine had 4 main metabolites. We have the first metabolite, berberine. The second one is the phthalate, then methyl berberine and jetroberberine. Excuse me. Therapeutic use of berberine. Berberine is being used for thousands of years in the treatment of hyperglycemia due to its hypoglycemic effect. Also, nowadays berberine is being used in many research for anti-cancer effect. Also, it has anti-hypertensive and antibacterial effect. Berberine effect on cytochrome enzyme. It is well known that berberine has an important effect on cytochrome enzyme. That means berberine will lead to decrease in many cytochrome enzyme activity, including the cytochrome A4, cytochrome 19, D6, C9, and cytochrome A2. Another randomized control clinical trial two groups of renal transplant patients that receiving cyclosporine A were included. Berberine was given to them as a dose of 200 milligram 3 times daily for 3 months. This study showed that markedly increase in the blood concentration of cyclosporine A in renal transplant patients, which could be attributed to the inhibition of cytochrome 3A1. That means berberine had an effect in the inducing the enzyme and resulting in increasing the concentration of drugs in the blood. Biomarker used in this study. We will use cytochrome 45017, which is the steroidogenic cytochrome. Also mitochondrial cytochrome B5 reductase as a biomarker. Also, we will test the level of testosterone free and bound, in addition to serum glucose and measuring the body weight of the rats. Material and methods. Induction of PCOS in female rats. We took Norway albino female rats, 8 sexually mature rats, 4 male and 4 female. Then the pregnancy was confirmed by observation of the vaginal plaque. Then we obtained about 20 female rats, the newborns, I mean. A study design and protocol. We have 2 stages in this study. The first stage was the induction of PCOS, and the second stage, investigation of function and morphological change after the use of berberine and the negative control drug, cyproterone acetate. Cyproterone acetate, as we know, it is commercial name is Androcure, is an androgen used in the treatment of androgen-dependent conditions like excessive hair growth, early puberty, and prostate cancer. In addition to PCOS, the direct anti-androgenic effect of cyproterone is blocking of binding of dihydrotestosterone to its receptor. So it is anti-androgenic drug. Okay, our study. We have 20 female rats, all induced PCOS, then divided into 4 groups. 5 rats treated with berberine, 5 rats treated with cyproterone acetate, 5 rats were only control, no treatment and no PCOS, and 5 rats had PCOS with no treatment. Then we took the rats at day 21 of their birth, and we induced PCOS by injecting testosterone propanoate 100 microgram per kg daily for about 28 days. That means 4 weeks. As you can see, the testosterone injection was introduced at the dorsum of the neck of the rat. Then we had to sacrifice animals for experimental, and 2 control females were selected at the end of the induction at day 28, randomly selected and sacrificed to confirm the development of PCOS in the experimental group. As we can see here, there is an obvious cyst in the ovaries of the rats. So we confirmed that they had PCOS. After that, the group of animals would be treated with 5 rats treated with berberine and the other 5 rats treated with cyproterone acetate. Then we investigated the effect of berberine on androgen synthesis in PCOS and compared it to the cyproterone acetate. For berberine hydrochloride, we took the berberine supplement from berberine hydrochloride 450 milligram per capsule from A-Square Nutrition USA. Then, for obtaining the required dose, we took 2 capsules and emptied them in 50 ml beaker and carefully waited for 900 milligram of berberine. 9 ml of the sesame oil was added to the beaker and thoroughly mixed to produce a light yellowish suspension. Then each ml of the suspension contain 100 milligrams of berberine using a small insulin syringe, which each unit contain 1 milligram berberine. We delivered the dose orally by gavage tube to the rats according to their body weights. Here we can see the berberine as a stock solution and dried fruit. Then here we choose the 18 gauge gavage tube to give the berberine orally by gavage tube to the rats on daily basis. Okay, results. Effect of berberine on serum testosterone. As here we can see, berberine in control group, there is free testosterone in nanomole per liter. There is a minimal reduction with no difference. Also, we can see in cyclotron acetate, the testosterone levels decreased from 9.5 nanomole per liter to 1.1. That means cyclotron acetate had a significant effect on the testosterone levels. Also, in 100 milligram berberine, the level decreased from 7.2 to 1.7, which is comparable to that of cyclotron acetate, meaning that berberine has a significant effect in reducing the amount of testosterone in blood. Here we also, lastly, we can see that PCOS level also remain high, which is a typical case in hyperandrogenized rats. In this scheme, we can see that from the pre-treatment, the berberine in red color had a high level of testosterone compared to PCOS and cyclotron. Then in post-treatment, the level of berberine, the level of testosterone greatly reduced after the treatment with berberine and cyclotron. But the level of the PCOS, testosterone in the PCOS level remain high. Effect of berberine on cytochrome 17A1, our biomarker. We can see in berberine group that the level decreased from 8.8% nanogram to 2.8 nanogram. Then the cytochrome acetate also decreased from 10.8% to 2.7 nanogram compared to the control and PCOS group. The PCOS group remain at higher level. In our graph, we can see that in red color, the berberine group and PCOS in blue color, we can compare them that berberine had a significant decrease in cytochrome 17A1 concentration, while the PCOS level remained high. Its effect on cytochrome B5 reductase, also we can see in berberine group, there is a reduction from 6.7 nanogram to about 0.6 nanogram. In cyclotron acetate, also it decreased from 6 to 1. Also in PCOS, there was a reduction from 7 to, it remained about 7. In our graph, we can see that in blue color, the PCOS group remain elevated in serum concentration of cytochrome B5, while there is a significant reduction in the amount of cytochrome B5 in the berberine group. Regarding the body weight, as we can see, there is a huge decline in the body weight in the berberine group. That means also we know that berberine had been used for centuries in the treatment of obesity. So as we can see in the red line, there is a significant decrease in body weight, while the PCOS group remain gaining weight. Regarding the serum glucose, we took the measurement at day 1, day 10, and day 28. We can see that gradually the fasting blood glucose regarding the berberine, the red line, started to decrease from day 1, then a minimal decrease in day 10, then a huge decrease in day 28. Also, regarding the postprandial blood glucose, here we can see that in red line, there is a significant decrease in the concentration of serum glucose after treating with berberine. We know that berberine has been used also for many years for the treatment of the hyperglycemia. For histopathological study, here we can see on the left the PCOS group on 100X and 400X, the obvious presence of the large cyst, also the presence of very small cysts. On the other hand, the right side on berberine treated group, we can see the disappearance of large cysts, which are typical in polycystic ovarian disease. Also, regarding the treatment with cypertron, we can see that there is a disappearance of the large cyst, small cyst, and the presence of corpus luteum in this slide. Okay, regarding discussion. Effect of berberine on the animal body weight. There was a significant reduction in the body weight in the berberine treated group with about 22 grams. 22 grams is very high for a rat. 22 grams with 11% decrease in the body weight of the rats. While there was a 21% increase in the body weight of the PCOS group. All we know that in polycystic ovarian disease, there is a marked increase in the body weight of female. So here we can see that berberine had a great effect on the body weight. The effect of berberine on blood glucose, as we mentioned earlier, postprandial blood glucose decrease in berberine from about 160 milligram per deciliter to 74. That's a 54% decrease in the blood glucose. Also, in cypertron acetate group, there was about 5% decrease in the serum glucose, meaning that there is no effect of cypertron acetate on the blood glucose. So the effect on blood glucose is only for the berberine.
Ahmed, you have a couple of minutes left. You have a couple of minutes left.
Okay, I'm finishing. The effect of berberine on serum testosterone, we can see here that berberine decreased the serum testosterone. Also, cypertron acetate was able to decrease the the concentration of the testosterone in blood, while PCOS remain high. Okay, the effect of steroidogenic enzyme, the cypis17A1 also decreased significantly after treatment with berberine. Regarding cytochrome B5, also decreased significantly after treatment with berberine, while in PCOS it remained high. In conclusion, we can conclude that berberine has a significant effect on steroidogenic enzyme, cytochrome 17A1 and cytochrome B5. And we can conclude that we can use berberine as an adjuvant therapy or as a supplement for treating PCOS and help with cytochrome B5. So, cytochrome acetate. Thank you very much. If you have any question.
Thank you, Ahmed, for your presentation. And we have a couple of questions, and I can see also a couple of questions in the Q&A session. First, I'd like to ask you, what is the current treatment of PCO? What do they use now in the clinic?
They are using a handful of drugs. For example, clomiphene. They are using estrogen. They are using combination of cypertron and estrogens. They are using metformin for body weight reduction. Disregarding the Iraq, but we can see in, for example, in America or in, as I saw in Iran, they are using berberine supplement for weight reduction and blood glucose reduction in PCOS.
Another questions I have with me. Do you have in mind any other animal model? You mentioned rats, and you used rats. Is there any other animal models for PCOS or other protocols that are used?
Well, I searched for many months for other animals, but I found that the rat is the best model because the rat had a very elevated tolerance for berberine. I read a study that said that rat can withstand about 100 milligram of berberine, while, for example, rabbits or mice can withstand a little amount. Regarding dogs and cats, berberine is toxic for them. So that the rat is the only animal that was able to withstand the berberine like humans.
I have another question here. Why do you use sesame oil here?
As you know that berberine is a lipophilic compound, so it would like to be dissolved in oil. Also, many studies use the sesame oil as a vehicle for dissolving many compounds, and it's palatable for rats and had non-effect. So it will not affect the therapeutic effect of the drug.
So I have a couple of questions here regarding bioavailability. You said it has low bioavailability, is that right?
Yes, yes.
Yes, so there's the questions in general are saying, is there any negative impact on the low bioavailability of it? Like now you're giving it immediately to the rat, or did you see any difference?
Yeah. Well, as I saw that this low bioavailability, I think it is responsible for its non-toxic effect, because very little amount of berberine is effective. So if it had a higher bioavailability, I think it would produce a toxic effect.
Dr. Huda is asking as well, why didn't you measure the androgen index?
Androgen index?
Androgen index, yes, that's what she's asking.
Well, according to my study, I think that measuring the testosterone alone is effective because I'm using Androcure, the cytotron acetate, and I'm trying to only measure the cytochrome 17A1 and cytochrome B5. So I think only the androgen, only the testosterone will be effective. Its increase or decrease will give me the answer.
Thank you, Ahmed. And the thing that is...
Hello? Can't hear.
Tahani.
نعم. نعم دكتورة.
See you, Tahani. So Tahani got her bachelor degree in pharmacy from the College of Pharmacy, Mustansiriya University in 2014, and she worked as administrator at the Department of Clinical Pharmacy from 2015 to 2018, and currently she's finishing her master studies at the Department of Pharmacognosy and Medicinal Plants. The title of Tahani's talk today is Phytochemical Investigation of Conocarpus erectus leaves cultivated in Iraq with isolation and identification of umbelliferon. Welcome, Tahani, and good to see you, and thank you for joining us. The screen is yours, and you can start sharing your slides.
Thank you, Dr. Athmar. In the beginning, I would like to express my deepest thanks, application to the Dean of College of Pharmacy, Prof. Dr. Munder, and Dean Assist Prof. Dr. Inam, and my supervisors, Dr. Ghaith and Dr. Abdul Muttalib, and to all conference organizer.
My title of this study is Isolation of the Amplefiron from the Conocarbis leaves of plant cultivated in Iraq. The topic of studies contained the introduction, aims, methodology, result, and discussion and conclusion. The Conocarbis erectus plant is also known as a buttonwood or button mangrove, is a perennial shrub or sometimes as a tree. Their height is extended from 4 to 20 meters. The Conocarbis is a genus comprised of 2 different species, include Conocarbis lancifolius and Conocarbis erectus. This Conocarbis plant is belonging to the one of the most important flowering medicinal plant, which is a Combretaceae family. Their geographical distribution is origin from the southern Florida, then extend to Brazil and tropical West Africa, and also cultivated in small area around the southern Red Sea coasts. In this study, we use the leaves of a plant. So the morphology of leaves of Conocarbis erectus, it's simple, spiral, opposite or walled, lanceolate, and sometimes with a pair of petiorial glands and axillary, fluorescence axillary. Their long of the leaves, it's extend from 2 to 10 centimeters. Traditionally, the parts of the Conocarbis plant used for the treatment of many of disorders, such as the anemia, diabetics, bleeding, conjunctivitis, gonorrhea, syphilis, while the decoction of the leaves traditionally used as antibiotic and anti-inflammatory, and the bark used for the treatment of hemorrhoids and wounds. The phytoconstituent of a plant, which is the naturally occurring chemical component found in the plant, also known as a secondary metabolite. In this plant, the reported phytochemicals or phytoconstituent, which is the phenolic acids and tannic acid, include gallic acid, ellagic acid, trimethoxyellagic acid. Also flavonoids such as the epigenine, catechin, quercetin, myricetin, rutin, and quercetin 3 glycosides, in addition to terpenes, and finally conocarbon belonging to neolignans. All phytoconstituents have a several biological activity to provide the benefits for the health of the humans. So the reported pharmacological activity, which is anti-cancer against the breast and hepatic cancer, also antimicrobial against the gram-negative, gram-positive acid-fast bacilli as a bacteria, and also as antifungal agent. In addition to have a good hepatoprotective and antioxidant activity. All the mentioned above phytoconstituents is reported previously, while the coumarins not reported previously in the other literature, so it's detected for the first time in the Conocarbis erectus plant leaves of the plant in Iraq. The coumarins is an important member of benzobiron family. They are basically, their structures consist of the benzene ring fused with the biron ring. The amplefiron is a 7-hydroxy coumarin. It is extensively spread within the Nemeros species of the families, which is the Rhodeaceae, Apiaceae, and Umbelliferia family. And some plants is rich with amplefiron. Example of it's the hemlock, fennel, parsley, carrot, and dill, cumin, and coriander. Chemically, the biosynthesis or the chemical synthesis of the amplefiron, it is attacked via the phenylpropanoid pathways from the trans-cinnamic acid. We show the trans-cinnamic acids, twice hydroxylated to form the trans-dihydroxycinnamic acid. The trans-dihydroxycinnamic acid cannot undergo the cyclization to form amplefiron because the not nearest proximity between the carboxyl group and the hydroxy group. So some plants in the presence of UV convert the trans-dihydroxycinnamic acid to cis-dihydroxycinnamic acid, and cis-dihydroxycinnamic acid undergo intramolecular cyclization to form the amplefiron. The aim of our study is to investigate phytochemical investigation of the leaves of the plant and for detection, isolation, quantification, and identification of amplefiron for first time from the ethyl acetate fraction of the Guanocarpus plant. In the methods, in the beginning, we collect the leaves of a plant from the botanical home of the College of Pharmacy. After drying it and grinding as a powder, the leaves will be defatted with the hexane solvent using the succinate extractor lead to form the hexane extract and defatted mark. Then these defatted mark, again, it's extracted using 85% of the methanol by using succinate lead to formation of the methanol extract. Then concentrated by using the rotary evaporator, then mixed with the distilled water and partitioned it with ethyl acetate solvent by using separatory phenol lead to formation of organic layer, ethyl acetate layer, and the aqueous layer contain the water. The ethyl acetate layer, it's concentrated and used for detection, applied to thin layer chromatography detection, and the amplefiron was isolated by using the preparative TLC. The methanolic extracts subjected for the preliminary phytochemical test to detect or qualitate the presence of phytochemical constituent of the plant, of the leaves, using saponin test, flavonoid test, coumarin, terpene, and test for tannin. In the result, the qualitative estimation of the phytoconstituent, it is revealed the presence of the flavonoid through the formation of the yellow color. Then it's converted to the colorless after the addition of the dilute acid, while the terpenes, formation of the interface with yellow to green fluorescence color, while the saponin form the persistent form after mixed the several minutes lead formation of the persistent form. Also the tannin lead to formation of the dark color after the add of 1% of the aqueous ferric chloride. The thin layer chromatography detection of the plant, it is applied by using 3 different mobile phase, and we detected through the conversion the RF value of the standard of the amplefiron with the standard of the sample. In this figure show the thin layer chromatography or TRC plate under the UV light at the wavelength of 366 nanometers show the spots of the ethyl acetate fraction with the standard of amplefiron. In this plate use the toluene ethyl acetate formic acid as a mobile phase. The standard of amplefiron are a value of it as 0.88, while the RF value of the sample of the amplefiron in the sample was 0.870. The isolation, here the isolation of the amplefiron is done by using a preparative TLC, which is a glass plate pre-coated with silica gel. This shows the band of the pure isolated component in compared with the spots of the amplefiron standard. The 3.3 gram of the ethyl acetate fraction yield 63 milligram, about 1%, as a light yellow powder of amplefiron. This is for quantitative estimation of the amplefiron. After isolated the amplefiron, we then subjected for the identification to show the isolated component or to prove the isolated component by 2 methods. One of them, which is the high performance thin layer chromatography. This is done by using toluene ethyl acetate formic acid mobile phase. This method used for detection of the component, also for identification of isolated component. Here show the ethyl acetate fraction, the standard of amplefiron, and the isolated amplefiron. So we compare the RF value of it by HPTLC chromatogram of ethyl acetate. This ethyl acetate fraction show the presence of 10 peaks show the presence of 10 peaks with a different RF value and with different area percentage. At the peak number 9, the RF value 0.77 consists about 5% as the area percentage. When we compared this chromatogram with the standard of the amplifiron, show the peak of the amplifiron standard and the RF value is compatible with the spot at with the peak at the ethyl acetate fraction 0.77. And when also compared with the isolated component, show the RF max RF value 0.79. Sorry. Another method for identification of isolated component, which is high performance liquid chromatography. In this method, we use the mobile phase consists of methanol, water methanol 30 to 70% with 1% volume by volume of the formic acid. The run is done when injected. This chromatogram of HPLC show for isolated component. Show the presence of peaks at the retention time. Firstly, the identification by the HPLC is through the conversion, the retention time of the isolated component with the retention time of its standard. So this is HPLC chromatogram for the isolated component. The retention time of the peak of isolated component appear at the 17.5 minutes, while the standard of amplifiron, the retention time peaks at 17.4 component, which is compatible to it. Structural elucidation of isolated amplifiron is done by FTIR spectrophotometry. The FTIR is the high resolution technique used to identify the functional group of the component of isolated component. From the structure of the amplifiron, that is contain the hydroxy, it is contain hydroxy, phenyl hydroxy group. This phenyl hydroxy group appear as the broad band centered at the 3,440 centimeter minus 1. This is the frequencies of it, while the carbonyl group of the lactone ring is appear at the 1740 centimeter minus 1 region, while the carbon, double bond carbon of the phenyl group or of the benzene ring is appear at the 1630 centimeter minus 1. Another method for structural elucidation of the isolated amplifiron is use the UV spectrophotometry. This UV can be indicate the presence the lambda max of the isolated component. The lambda max of isolated amplifiron appear at the 324 nanometer as a broad peak centered at the 324. These all results, it's also agreements by the compared it with the previous literatures. From all the results, we conclude the preliminary phytochemical analysis revealed the presence of saponin, flavonoid, terpenes, tannins, and coumarins. Also, the first time detection isolation of amplifiron from the Iraqi conocarbis plant, not reported in the previous studies. Quantitatively, the isolated component yield 63 milligram as a yellow powder. Thank you for attention.
Thank you very much, Tahani, for this presentation, and good to see you again. I have a few questions for you. First, is this plant, if I say it right, Conocarpus erectus? Is it only present in Iraq or it's present in another country?
No, present in another countries. I mentioned there the geographical distribution. It's extended from the Florida, then Brazil, and India, Pakistan, also in the around the regions around the Red Sea.
So have they extracted amplifiron before? Have they extracted amplifiron? Is it extracted before? Is it reported before in these countries?
No, not reported previously in other studies. This reported in Iraqi plant.
Just in Iraqi plant. So you had extracted this material. Did you extract or isolate another compound?
Yes.
Or it's just this material?
Yes, in the master research, I isolated 4 materials such as lopiol from the hexane extract, as a triterpene, also gallic acid as a phenolic acid, camphorol as a flavonoids from the ethyl acetate fraction, in addition to the amplifiron.
And all of them had activities, or you didn't check them? You only focused on amplifiron?
No. In the beginning, the amplifiron have a number of pharmacological activities, such as the antifungal, antibacterial, and as a hypoglycemic activities. I will use in the study. We subjected the ethyl acetate fraction and the hexane fraction for the cytotoxic activity against both breast cancer, MCF7, and pancreatic cancer. But it is published in another journal.
Okay. Another question I have here: which part of the plant did you study?
The leaves of a plant.
The leaves of the plant.
Leaves.
And I have a question in the question and answer part. Nuhad is asking you, could you explain briefly how did you choose your solvent system?
Yes. Solvent system, we use methanol water, 80-20%, and we use the toluene ethyl acetate formic acid, and in another, the third solvent system, just a minute.
So what these percentages of the solvent system, how did you come up with them? Were they already there in the paper and you used them, or you adjusted them according to your plan?
No, this is reported. Sorry.
No, it's fine. It's fine. It's fine, Tahani.
This is reported. It is found in the plant drug analysis. This mobile phase, so it used to مجرد طبقتها مثل ما هي موجودة على الامبليفيرون.
Another question from Zahra: why coumarin secreted or present in the plant?
Some of phytoconstituents, such as the coumarin, can be plant used it or produced it when it's as a defense mechanism when it's exposure to the microorganisms such as bacterial and fungal, and as an enzyme inhibitor, also as an antioxidant. This is a benefit or defense mechanism for a plant to define itself. So in Iraqi, sometimes the environmental pollution maybe lead to produce the plant of this amplifiron and not reported in the other literatures.
Thank you very much. Thank you very much, Tahani.
Thank you.
At the end of our day-to-day or our section of the presentation, I would like to thank all our students. And now we can have a vote. Which research or which presentation you think benefit you the most, or it was more interested, the presentation was better, in your opinion? All of them are perfect, all of them were good, all of them are our students, and we follow them through their studies, and we know how hard they work. So it's now up to you, our audience, to choose which of our students did a little bit better than the others today. You can start voting now. You have the names of the students and the name of their research. And I would like to take a chance to see everyone. So if you kindly all open your cameras for us, the panelists and our presenters today, our presenters from the other days if they are present. And we are waiting for the vote at the moment. Yeah, I can see a lot of lovely faces here, and I'm waiting to see more. I hope you can all open your cameras for us. Thank you. And And we are waiting for the results of our poll. Vote for representation. Mace, where she talked about the curcumin as an adjuvant therapy. Noha, where she talked about the preparation and evaluation of the porosity osmotic tablet. And Sam gave us an idea about the effect of D3. Rafid also talked about the synthesis of anti-cancer evaluation using the molecular docking study. Sarah talked about design synthesis of antibacterial new agent. Ahmed gave us an idea about the potential effect of berberine, and Tahani finally gave us an idea about the phytochemical investigation of Conocarpus leaves.
%51% of the population has voted. That's about 118 votes so far.
And so far, who's in lead? Can you give us a hint, or you're keeping it to the end?
Okay, let's do it. Let's give it another 30 seconds.
Okay.
Now the race is between Tahani Amr, Rafid Muhammad. They share the same equal number of votes. I'll be sharing it as soon as we finish in a couple of moments.
Thank you.
Okay, that's it. I'll be ending it, and I'll be sharing the results so that everyone can see it ahead.
Go ahead.
So there you go.
So as we can see, we have a tie. We have Rafid and Tahani, or am I seeing it wrong?
By a single vote. That's
by a single vote. So
right.
Who is the winner? Tahani is the winner.
Yes.
Everyone is a winner.
Everyone is a winner today, of course. And we are also winners because we have the chance to meet them and to hear them talk again. So congratulations, Tahani, for the day. Congratulations, everyone else, for participating today.
Thank you, Dr. For you.
And Dr. An'am, you can take it from here.
Yes. Thank you very much. Thank you, everybody. Thank you very much for the speakers, for the students who displayed their work. Thank you for the moderators. Thank you for all the attendees who spent that time for 3 successive days with us. And we would like to see you soon again in another new event. Before we wrap up, I would like just to read for you the recommendations that we have ended up with, just to have an idea about it. So the recommendations of our conference was categorized into two sections because, as you know, we have the current situation concerning the COVID-19 pandemic and the general condition for the pharmacy education. And since everybody thinking that whenever the pandemic will abate, so the students, the academics, and the general health system will be forever changed. So we have to think about it seriously. So the first category, since the outbreak of the coronavirus is continuing and we cannot precisely know what will happen, so we are enforced to think deeply about curriculum transformation that include more active learning to keep sustainability of pharmacy education. This should be done through, first, think seriously about accelerating opportunities for models of education. Second, focusing on consistency across each year of the academic program. And if possible, we can go through the whole curriculum. This done by creating consistency, educators can easily help each other. Third point, more interactive response to questions and activities in between the lectures. So this will enable the students to test their concepts continuously. Fourth, continuous communication with the college members, staff members, and the students. This is for the coronavirus situation. The second section, the general recommendation. First, develop and implement competency-based pharmacy education to better prepare pharmacists for their role as a part of the healthcare system. Second, develop and implement quality continuous professional development programs. Third, develop accreditation standards and quality assurance guidelines locally and regionally to address and standardize pharmacy education and practice. And finally, think seriously about creating new job opportunities for the new graduates aligned with their new knowledge and skills. Thank you very much for your attendance and wish you all the best. Thank you very much. See you soon. The final closing remarks would be with Dr. Munder. Dr. Munder, the microphone for you. Dr. Munder? Is there a problem?
I don't think that he's hearing us. I think that he's having some technical difficulties.
We will wait for him for a few minutes. I think there's a problem with the electricity, so we can wait for a few minutes.
Sorry, net. Are you okay?
No problem. Yeah, okay.
Sorry for this interruption. Finally, ladies and gentlemen, on behalf of this conference organizers, I would like to express our gratitude to all you guests and lecturers who have come together from various countries for your cooperation, which made this event a success. It is a great pleasure to be part of this opportunity to discuss and exchange knowledge in such challenging times, and I promise to work hard to make it happen again in the future. Best regard and thank you for all.
Thank you very much.